Right. Hi, everyone, and welcome to today's session on gastroenterology. Firstly, a huge congratulations on finishing medical school and securing your foundation jobs. Starting life as a doctor can feel very exciting, but also very overwhelming, and that's completely normal. So today's session will hopefully act as a practical guide to things that you'll encounter most during your gastroenterology rotation. Um, okay, so if we go on the next slide, if that's okay. Thank you. So it's my pleasure to introduce you to our next speaker, which is Dr. Max Wood. Max is currently a Foundation Year 2 doctor and will shortly be starting as an Imperial Undergraduate Clinical Teaching Fellow. He completed his FY1 year in Gastro before rotating through emergency medicine, general practice, and acute med during FY2, giving him plenty of experience managing the common presentations that you guys will see as Foundation doctors. He's got a particular interest in gastroenterology and has fantastically got an outstanding ARCP during his foundation training. So in today's session, he'll be sharing the practical tips, clinical pals, and ward-based advice that he wished that he had known for starting his gastro rotation. Before we move on, I just wanted to take a minute or so just to tell you a little bit about Medics&Me and some of the resources available to you. So we now have a growing library of foundation prep sessions that you might find helpful. So far we've covered general surgery, urology, neurosurgery, respiratory, as well as renal medicine. And we've also got some upcoming more sessions on geriatrics and cardiology, and they will hopefully be available on our YouTube channel shortly. Alongside these teaching sessions, Medics&Me offers careers blogs, teaching opportunities, quality improvement, and research projects, as well as mentoring opportunities. So whether you're looking to build your portfolio, get involved with education, or simply make that transition into foundation training a little easier, we'd encourage you to explore what's available. You can also follow us on social media to keep up to date with any new sessions that we have, any resources, as well as any opportunities that we have. So without further ado, I'll just hand over to Max to get started on the session.
Lovely. Thank you so much, Sarah. So yeah, as Sarah said, my name is Max. I'm currently an F2, just finishing up on my acute medicine block. I am actually in the acute medicine meeting room right now. That's where I'm doing this from. Post a lovely shift on the AMU. In terms of kind of what we'll be covering today. So, let's see if I can just hide this. We're going to be concentrating on gastroenterology. That's what I'm interested in. It's the job that I enjoyed the most on F1. And I think if you kind of know a little bit about it before, you can really get loads out of it. And you can really have a good time on a gastroenterology job. What we'll cover is expectations, what's expected of you at this level as an F1 or an SHO. I'm going to be pitching it to both F1s and SHOs because I think there's quite a lot of overlap. We'll talk a little bit about history taking and clerking, some common pathologies that you might see, the must not miss emergencies, a typical day, what you might expect from morning till 5 p.m. Diagnostics and investigations, so a little bit of a recap on some med school revision, but kind of the more clinically appropriate stuff, and especially at your level. Procedures and skills that you can get involved with, and I definitely encourage that you do. And then a little bit about opportunities, portfolio, your well-being, and then finishing off with a little bit of top tips. I will try and keep it as high yield as possible and not go over. Yeah, so let's get started. So, expectations. So, just a few bullet points of what is sort of expected of you as an F1 or SHO, and it's kind of going from the morning, from when you come in the morning, and you're most likely waiting for your consultant or registrar to turn up. It's always good to know the patients, know the list, and specifically to that is know who's new on the ward. That's easy if you spent a lot of time on the ward that week. But maybe talk to the nurses, know who's the new patients and who's the sick patients because they are the priorities. So maybe who's scoring a high new score or who had some events overnight that need addressing. And then also who's got investigations. So particularly for gastro, it might be things like MRCPs. ERCPs, going to endoscopy. A lot of the time, nursing staff will know this really well, and it would be good for you guys to know it as well. So know the patients, know who's who, know who's sick, know who's new. Didn't mean that to rhyme. And then ward round. So you've all been on ward rounds. Gastroenterology is usually no different. You've probably been on gastroenterology ward rounds. Your expectation at the start is to present and document. So that is go around with your consultant or your reg, present to the patients and your knowledge of them. That means like having a little read through before. Talk about what their working diagnosis, what they're in for, what's happened so far, and what's the next steps, as well as some kind of investigations that might have happened recently, and then document. You might have done some documentation as a med student before, you might not have, but it's a skill that you will just kind of develop. You'll probably form a little bit of your own style as you go along. Just try and basically say what the consultant is saying to the patient, and do not be afraid just to double check things, because when that consultant leaves or the registrar leaves for their other duties of the day, that documentation that you've written is what you're relying on to look back on to see what's going on. And then as you get more confident within a job, you might start seeing some patients alone. Know the gastro basics and key investigations. So a lot of this stuff you probably will know from med school or from your F1 if you're going in as an SHO. But just it goes a long way to know and maybe do a little bit of reading before the basics of gastro, and we'll go into that. Some things that you're expected to sort of manage on your own, kind of sort of day one, like in the first few months, is classic thing on the gastro ward is electrolyte replacement. You will have refeeding guidelines as part of your trust guidelines that will document that have a very clear plan of, if your magnesium is this, give them this. It's very easy, but it's something that you can do alone. You'll be expected to be able to kind of interpret some bloods, do things like fluid prescriptions and fluid management and stuff like that. Again, all of this is caveated with, if you're unsure, ask your senior. And then other things, who is where and how to contact them is really important. Most hospitals use Accurex, I think, and the app where you got lots of numbers, extensions to who to contact. But it's also really useful just to know where these things are in the hospital. So where is endoscopy? Where is imaging if you need to go and talk about an MRCP? Do you do ERCP in your hospital? Do you need to? Is it when I was doing an F1, ERCP was done at the Royal Free, and I was at the Whittington, so we had to know how to escalate that to the Royal Free. And then escalating sick patients is an expectation of an FY1 SHO. So a skill again that you've learned in med school, but the recognition of how to recognize and escalate a sick patient and know who to call. So a little bit about clerking. Again, I'm sure you can all take a very good gastro history. So a little bit of obvious points is gastro past medical history. And in that, previous OGDs, colonoscopies, any liver scans, any kind of gastro-related imaging or investigations is really important. A lot of the time, a lot of the patients you see will be sort of alcohol excess patients. It matters a little bit on where your hospital is, but certainly for me, a lot of the patients on the ward are often alcohol excess patients. So knowing how to do a good, confident alcohol history is really good. I put ask twice, maybe ask 3 times, because a lot of the time we won't get a straight answer first time. And just try and, as much as you can, put across that there's no shame in kind of being honest about your alcohol history, because it's really important for the care. And in the alcohol history, make sure you know when that last drink was, because that's important for alcohol withdrawals. Other key bits in a gastro history, if they've got some D&V, diarrhea and vomiting, make sure you include a travel history, because when you call micro, they will often ask, and actually that extends to general micro conversations. They often want to know where that person's been in the world, because even though you might not know that them going to sort of Morocco at this time of year, it means that they're more likely to have this infection. Micro will probably know, so it's good to just do a travel history. Kind of going back to the refeeding stuff, nutrition history is really good, especially if they're alcohol excess, they might not have been eating as much, they might be risk of refeeding. Also, a lot of the time, gastro patients will also be malnourished patients, so they often have a high risk of refeeding. So ask a little bit about kind of what they eat on a daily basis, how much they've been eating in the past week, and things like any weight loss or anything like that. And then also, again, I'm sure you would ask, but family history, any history of GI cancers. And I put be intentional at the bottom here. And I think this is something that I like to do with all my teaching, with all the history and examination teaching is I feel in med school a lot of the time when you're revising for OSCEs or your exams, it's very tick box, and you're now going from kind of an abdo examination being make sure you do all the steps in the right order and make sure it looks like you're doing it to an abdo examination actually being, I'm really trying to figure out what's going on with this patient. And in the history, you go from an alcohol history being cool, I've asked about alcohol, tick, they've answered, to I really do want to know how much this person's been drinking, when they stopped drinking, and if that's really important to their history. So be intentional with your question asking, with your examinations, because it's no longer kind of tick box. It's now you're actually trying to figure out what's going on. So if you've asked about something and you're not quite sure, or you don't feel like you've got a clear answer, ask again and go back to examine again, and just try and be intentional with all of that stuff. Cool. Common pathologies. So I've split this up into things that I was sort of expecting to see, and things that I actually saw mostly. And again, this I put in the bottom there. This does depend on your center. This does depend on where you'll be working in gastro. I was working at a DGH. It was not a tertiary center, and it was in North London. Other people have different demographics. They might be at different capabilities in that hospital. So you might see kind of a mix of different things. It might be specialist for hepatitis or something like that. So you'll see a lot more. But I was very much expecting from med school to be seeing ulcerative colitis, pancreatitis, hepatitis as like my big things, along with some decomp, cirrhosis, bleeds, and then also like some liver injuries and cancers. That's kind of what I was really expecting from what I spent most of my time learning in med school. Overwhelmingly, like I said, what I saw the most was alcohol excess and alcohol withdrawals, and with that does come alcoholic decompensation of liver cirrhosis, and alcoholic liver injury. So I think it's good to know a little bit about withdrawals and how to manage them, especially you'll be on your Gen Med rota most likely as well. So you'll be doing take post take. So you'll be seeing a lot of these patients anyway through the take. So knowing a little bit about CWA scoring, which I'll talk about a little bit later, about your local withdrawal protocol, so benzodiazepine protocol, and knowing Pabrinex and thiamine regimens for alcohol withdrawals is really important. Another really common thing was decompensated cirrhosis. It's those patients who have maybe been living with cirrhotic livers or liver failure for a long time, and something tips them over the edge, whether that be an infection or an alcohol binge, or something, and they come in decompensated. So it's a difficult thing to manage, and obviously your consultant will be managing it, but you'll learn a lot about decompensation and what to look out for. And in general, the things to look out for what decompensation is jaundice, ascites, hepatic encephalopathy, and/or variceal bleeds. So that variceal bleeds or coagulopathy. Other common things, refeeding syndromes, which we kind of touched upon a little bit. It's good to know the pathophysiology of refeeding syndrome. A lot of this you will also learn on the job, so don't stress yourself with learning loads of stuff before. Upper GI bleeds. I think it's good to be able to recognize, definitely good to be able to recognize an acute upper GI bleed and know how to know if it's severe or not. And then also acute liver injury is also a very common reason to be on a gastro ward. Again, that's overwhelmingly alcohol from my experience. I saw some ulcerative colitis and Crohn's flare. We have one patient on the AMU actually now, which is a UC flare. I saw maybe in my centre 3 or 4 hepatitis cases, some cancer cases as well. They are often palliative cancer cases, especially pancreatic cancer, and then also pancreatitis. There's a little bit of play between the surgeons and gastro about who looks after pancreatitis. I know at my hospital, generally first presentation pancreatitis goes to the surgeons, recurrent pancreatitis, as long as it's not a surgical pancreatitis like a gallstone that needs surgery. The first presentation goes to surgeons, then it comes to medics. So that's a little bit, I think there's not a stark difference between what I was expecting and what I saw, but I think the main thing there is a lot of sort of alcohol-related liver injury and withdrawals was my biggest kind of surprise when I started on the gastro. Must not miss emergencies. So I've got 4 of the main ones here. And I've got them on the side, but things like sepsis and bowel ischemia and perf, I've sort of put to the side because they're more general or surgical. These are sort of the very gastro ones. So the first is an upper GI bleed. Now, this is the most common and probably one of the most emergent emergencies on gastro. In terms of how to manage these, generally rules are look at history, know if this person has had upper GI bleeds before, know if they've had previous OGDs before, do they have varices, do they have known ulcers, think about kind of where this bleed might be coming from. Think about the signs of an upper GI bleed. So very, very obvious signs are hematemesis. So that's frank red blood coming up in vomit. People talk often about coffee ground vomit as well. That's more like digested blood that you're vomiting up. Tends to be less of a specific sign, but it's still very, very severe. You've got to take it very seriously. Melena obviously is a very, very sensitive sign for an upper GI bleed. And then very importantly, observations, are they stable? In general, the approach to upper GI bleeds is you resuscitate first. So you make sure you get them to a stable point first, and then they go for OGD, usually between 12, 16 hours after presentation, as long as they're stable. Some will go straight to OGD if they are unable to make them stable. So resuscitation is obviously mostly fluids replaced with bloods, and there's some nuance around not trying to replace too much so that their blood pressure goes too high and you promote bleeding. In terms of classifying bleed risk before endoscopy, the Glasgow-Blatchford score is your friend. If you're going to speak to someone about an upper GI bleed, make sure you've calculated the Glasgow-Blatchford score before, and also just have an idea of what their odds are at the moment to see how urgent it is. And then one more thing about upper GI bleeds: variceal bleeds will always need antibiotic prescription if it's a variceal bleed before OGD, because it has evidence to reduce mortality. That was a little bit hodgepodge. Sorry, that was a bit to and fro with upper GI bleeds, but have a little read. It's good to know about them. It's good to be able to recognize them. Obviously, I said you resuscitate first, ideally, and then you go for OGD afterwards. That doesn't mean don't contact the gastroenterology consultant immediately if there's a serious upper GI bleed. Spontaneous bacterial peritonitis is another must not miss, SBP. There will be clinical signs, of course. They will have a tender abdomen, most likely. They often have a distended ascitic abdomen, and they will be very unwell. They will often have fevers and sometimes might be septic. But the gold standard to knowing whether this is SVP or not SVP, and you should be looking somewhere else, is Ascitic tap. And the golden rule for Ascitic tap is if the white cell count is over 250 from the Ascitic tap, from the Ascitic fluid, and if it's predominantly neutrophils in that Ascitic tap, then that's diagnostic of an SBP, and they need to start on IV antibiotics immediately. Acute liver failure is another one. I didn't see this as much, to be honest, but it's definitely good to know about it, and know a little bit about transplant criteria. Quite a consultant topic, really, quite a more registrar consultant topic, but the MELD score, MELD, is good for knowing about transplant criteria, and that's good. That's a good one. If you haven't got the app MD Calc yet, I'm sure a lot of you have. A lot of these scores are on there, which is really good. Finally, delirium tremens is severe alcohol withdrawals with quite a high mortality rate if they're not treated. So if your patient is having hallucinations or alcohol withdrawals, seizures, or if they're known previous alcohol, they have known previous alcohol withdrawals, then think about delirium tremens and start that benzodiazepine withdrawal protocol. So they're your must not miss emergencies. Again, on the right, I've got severe pancreatitis, sepsis, severe electrolyte abnormalities, and bowel ischemia. I'm not going to talk about those as much in detail for time, but those are your what I've come up with for must not misses. So cool. A little bit about a week in the life of an F1 and an SHO. These are two of my rotas. So the first is FY1 in gastroenterology. The SHO rota is my SHO rota in AMU, acute medicine. I was quite surprised actually looking at this when I saw these. I think F1, so just to talk to you through this a little bit, F1, the blue are standard shifts, so that's me or you on the gastroenterology ward, doing your ward rounds, doing your jobs, going home at 5 o'clock hopefully. Any weekend shift can be either ward cover, so that's where you are looking after multiple wards and you're going through the out of hours list and doing jobs from the out of hours list or the weekend list. Some hospitals will do ward rounds for gastroenterology, some won't. Or you're on take or post-take for the weekends as well. So they're different colours. And if you don't know, take is where you are sat in the emergency department and you are clerking patients that have been admitted under medics and starting management for them. Post-take is where you go around with a consultant and you see patients either in ED or the wards for their first consultant review. You do the jobs. And then, so as you can see there, in about 21 weeks, sorry, I'm going to sneeze. In 21 weeks, on the weekdays, I've got 1, 2, 3, 4, 5, 6, 7, 8, 9 long days on the weekdays, plus 4 weekends. It's a lot more busy in SHO, as you can see, and it's a lot more varied. I think this is maybe because I'm doing an acute medicine job at the moment, so I do things like SDEC. I do a lot more take and post-take. But in general, F1, you are probably on the ward more than when you are as an SHO, and your job is more kind of consistently ward-based with some take, post-take in out of hours compared with SHO. Cool. A little bit of knowledge recap. So talking a little bit about diagnostics and investigations. Starting off with Ascitic tap. I've sort of mentioned this already, but for SBP, the golden rule is once you've tapped the fluid and you've taken out some fluid, you send that off to the lab and you're looking out for the white cell count. If that white cell count is under 250, it's normal, or it's ascites due to cirrhosis. If it's over 250, it's abnormal. If it's over 250 and predominantly neutrophils, this is diagnostic of a spontaneous bacterial peritonitis. If it's over 250 and it's predominantly lymphocytes, this is maybe TB or malignant. It's more up for interpretation based on the case. But the golden thing is neutrophils over 250 SBP. Obviously, you'll send off cultures and other tests as well. The other important thing for Ascitic tap is figuring out, similar to pleural taps, if it's transudative or exudative. I like to think about this is if it's exudative, so if it's kind of an inflammatory process, that inflammation in the body will cause your vessels generally to become a little bit more leaky, and that allows protein like albumin to leave the vessels into the ascitic space, into the peritoneal cavity, and so you'll have more albumin in an inflammatory state in the ascitic fluid in the peritoneal space, compared to if it isn't in that inflammatory space. So what you can expect is that in an inflammatory, like an SBP or malignancy, that you will have a lower serum albumin to ascitic gradient. So it will be under 11 because you've got more albumin in that ascitic fluid. If it's over, it's more likely not inflammatory and it's due to something like portal hypertension, cardiac failure, or a portal vein thrombus. So SARG, SAAG is your friend. Make sure if you do an ascitic tap, as well as the white cell count, you send off protein or albumin content. And then you do a paired serum sample, so you take bloods as well when you do an ascitic tap. Refeeding guidelines, I've not got anything to show you here, I'm afraid, but what I'd say, and I've done it in my AMU office as well, and I think it's really helpful. I think you come across this so often, and you always think, oh, how do I replace phosphate, or how do I replace potassium again? What's the regimen? So print off your refeeding guidelines, I'd say. I think you're referring to them quite a lot, and it's really important. And it's often just like a quick job that you do while I sat in the office. You just see, oh, look, they're low in phosphate, we need to replace that. Of course, think about the wider context as well, if they're refeeding or why they're low in those electrolytes. And also think about if it's severe. So if you know your potassium is above 6, and you've got to start thinking about bringing it down medically. But yeah, refeeding guidelines you will come across a lot, so I'd say stick them up in the office. Coagulation screen. This is a little bit more of like a complex kind of thing to think about. But I just remember being taught a little bit about this when I was on my gastro placement, and it just been quite a helpful thing to keep in the back of my head. Often your INR, so your coagulation screen, is used to assess the synthetic function of the liver. And that's because your liver produces a lot of the procoagulation factors and clotting factors. So your INR in a liver failure will often be off. However, in liver failure, when your liver's synthetic function is poor, you get what's often called a rebalanced state. So you are both more prone to bleeding and clotting at the same time. And that's because your liver makes both procoagulation factors, like the ones listed here, but it also makes anticoagulation factors. So you are at higher risk of both bleeding and clotting at the same time, which makes a coagulation screen on your blood tests quite difficult to interpret, and again, probably one to run by the reg. But essentially, the learning point here is don't always, on face value, trust the INR when you've got patients with liver cirrhosis. And also, just to add on there, there's other things like CRP that's made by the liver. Don't always trust CRP when you're in liver patients. They can be a little bit more complicated to interpret bloods because a lot of things are made by the liver. NILS. So NILS is a common diagnostic tool, and it stands for non-invasive liver screen. So it's your blood panel to look at why is this person's LFTs deranged, essentially. Often if you refer to gastro, like I often do from AMU, or if you're in gastro, the seniors will request for a non-invasive liver screen. Again, actually, I would say this is probably a good thing to print off and put up in the office as well, just so that you have it there and you know exactly what is included in a non-invasive liver screen. It's a screen to look at, I've kind of already just said this, but to look at why is it a hepatitis? Is it immune mediated liver failure? Is it something weird like Wilson's disease? So you'll often be asked to do a NILS panel. So I'd say print it off, or maybe your hospital has a protocol on there when you order bloods for a liver screen, and it might be all on there anyway. But yeah, good thing to know about is NILS. It's good to know about some common diagnostics and investigations. Sorry, some common imaging. So probably most commonly, specialist imaging is an MRCP, and that's to look at the biliary tract and if there's any blockages in that biliary tract. Probably one of the most common. It's an MRI. Liver Doppler is looking at blood flow through the liver, and is often used for things like Budd-Chiari syndrome, also to look at things like portal hypertension. Your consultant may ask you to order a triple phase liver CT. That is a specialized CT of the liver that looks at blood flow through the liver in 3 phases, and it's often used to look at specific matters and or benign. And then also FibroScan, which you'll probably know, is to look at the level of cirrhosis in your liver or scarring in the liver. Why do you need to know about these? Because a lot of the time it might be you calling up the radiologist to vet these. So it's good to know a little bit about what they do and why you need them. Again, similar to my tip around always ask the consultant when you're documenting, just to clarify things. Always ask for indications for things. They will often be like, oh, do an MRCP or do a CT triple phase. And you'll write it down in your plan. And you're like, cool, CT triple phase. And then you'll get to 3 o'clock or whatever when you order that scan, and you'll have to vet it and you have no idea why. So always try to just clarify indication for things with your consultant. And then finally, SIWA scoring. SIWA scoring is a way to classify withdrawals, alcohol withdrawals in particular. And it's a scoring system often done by the nursing team. And it will classify how severe their withdrawals are at that point in time. And based off that, they will give either chlordiazepam epoxide or oxazepam, any sort of benzodiazepine, whatever's the trust policy where you work. And they will give you it will give you a score, and you give benzodiazepine dose based on that. It's usually done 4 hourly, and the way it usually works is you do SIWA scoring in an alcohol withdrawal patient for the first 24 hours of their admission, and then based off their scores and how much benzodiazepine they've had, you then prescribe a weaning regimen, so a regular regimen of benzodiazepine that gets smaller and smaller in dose as the days go on, based off that first 24 hours and how much they needed. Little caveat to SIWA, if patients are patients that present quite a lot, it's quite an easy one to, so some of the categories here are things like anxiety, visual disturbances, headache, and if patients sort of know what they're doing, you can quite easily falsify a SIWA. In general, you just trust them and you give them what the SIWA says, but just maybe keep that in the back of mind as well. Cool. So that was a little bit about diagnostics and investigations. Sorry, I feel like I'm firing a lot of information at the moment, but hopefully some of it is sticking, and you can always come back to this recording and look at little bits as well. I'm just going to quickly touch upon scoring systems because Gastro have a few and they're often really helpful. They're helpful for foundation doctors because they make your referrals quite legitimate and evidence-based, and they also give you a sense of a severity of a situation as well in a very objective way. So to go kind of from the up here, the modified Glasgow-Imrie is that pancreas pneumonic. It's one that is really useful for knowing the severity of a pancreatitis. And again, it'll be really good if, you know, on that ward round when you say, oh, so and so is day 2 with the pancreatitis first presentation, his Glasgow-Imrie score is this. It will be quite impressive as an F1 or SHO. Also, quite impressive is if you are on take and you admit a pancreatitis, is to do all of these tests. So do things like LDH and calcium and glucose as well, because it makes it easier to calculate that score later down the line and kind of compare. The Rockall score I didn't really use, to be honest. It's a post-endoscopy score, risk of bleeding for upper GI bleeds. You can use it if you need to, but that's what the Rockall score is for. I didn't use it loads because I'm never did an endoscopy in my F1, funnily enough. Child-Pugh score is to look at cirrhosis severity, and it's quite a simple one. It's just got A, B, C, D, E categories, 5 categories. Your MELD score, similar to Child-Pugh, it also is a severity score for cirrhosis, but it's more used for transplants and trying to figure out whether a patient needs a transplant. And then the one on the bottom right here in the grey, that is the Glasgow-Blatchford score. And again, if you're referring any kind of upper GI bleeds, it's always good to do the Glasgow-Blatchford score. That being said, if you score for having heart disease or liver disease, then you're automatically high risk, especially if your age scores as well. You're automatically high risk and you need an inpatient endoscopy. But yeah, they are the kind of 5, I'd say, scores. Maybe I'm missing a few for gastroenterology. Cool. A little bit on procedures and practical skills. And this was probably one of my favorite bits, if not my favorite bit of gastroenterology, because I remember starting as a gastro F1, feeling very nervous, feeling very new, feeling like I didn't know anything about gastroenterology. And I think in my first week, I was asked, do you want to go down to Ascitic and do an Ascitic drain? And I thought, oh my goodness, that's so scary. But I did it and it was cool. And I ended up doing quite a few Ascitic drains and taps over my time as an F1 in gastro. And I left with a new skill. So I'd say procedures and practical skills can be scary, but as long as you've got a senior there who is talking you through it, you're in safe hands, and I would just say go for it. It's very, very useful. As early as you can, start doing procedures and practical skills. I don't know if you're someone that enjoys doing it, but I always like the opportunity to leave the ward office and go do a procedure for a little bit and not be doing a TTA for a little bit. So if you're someone that is able to do useful procedures and practical skills, it makes you quite an invaluable person on the ward. So when you have opportunities, I'd say go for it. So Ascitic tap, I'm only going to talk about Ascitic tap and Ascitic drain for practical stuff. So, and they're very similar as well. So Ascitic tap is your diagnostic test for ascites. So that's wanting to answer the question, why has this person got ascites? Is it portal hypertension from liver failure or cirrhosis? Is it SBP? Is it malignant? Is it TB? So you're doing a tap to diagnose, and you're doing those white cell counts, culture. Oh, it's all here. Cytology, so that's looking at the white cell counts. Gram staining to look at what type of bacteria is there. Microscopy, culture and sensitivity, again, looking what bacteria might be there and what antibiotics are sensitive to. And then albumin, protein, LDH, glucose, white cell count. That's to do your SOG and to classify that. ascitic fluid further. That, again, might be a little thing just to kind of keep in your photos on your phone or something. Oops, sorry. Just to know what to order when you're doing ascitic tap. On the left here is an ultrasound image. I would recommend, a lot of old school doctors will do taps and drains without ultrasound. I would just recommend doing ultrasound. It's safer for the patient. This is an ultrasound image of, I don't know if you can see my cursor too well, but the top obviously is ultrasound. So this is the skin and some subcutaneous fat, and you dive straight into lots of acidic free fluid where it says nicely free fluid here. And then what you can see here is bowel and mesentery. So essentially what you do for an acidic tap is positioning is really important. You get the patient lying on their back. Often it helps if you tilt them to their side where you want to do the tap, because that helps shift the fluid. Remember that shifting dullness, shift the fluid into the space where you want to tap so you have more to go at. And then you palpate, you have a little look with the ultrasound, you say, oh, look at all that fluid, that's great. And then you mark it with the tip of your needle cap, and then you do your you do your aseptic techniques. So you don up, make a sterile field, do some chloro prep over the point where you've marked, and then you use a green needle in the top and a syringe, and you just poke through. It's very easy as a skill, and I think a lot of people, when they do the first one, are quite surprised how easy it is. Some people will use local anesthetic. The argument against local anesthetic for a acidic tap is the whole thing without local anesthetic involves just one needle, and if you're doing local anesthetic, you're doing two needles and one without local anesthetic, so it's sort of the same. But give your patient the option and explain that to them. So that's taps. That's for diagnosis of acidic fluid. And that's to just draw off a little bit of fluid so that you can send them off to the lab and get them tested and figure out why they've got ascites. Drains are more symptom relief. Of course, you're removing fluid. You can collect that fluid, you can send it off to the lab, so they can be diagnostic. And you might do just a drain if you want both diagnostics and symptom relief. But yeah, drains are for symptom relief. And what a drain is essentially is a big cannula that you can see on the grey kind of picture. Big cannula that you insert into the acidic space, into the peritoneal fluid, and you let drain. And for the patient, if you can imagine sort of 10 litres more of fluid in your belly at any one time, especially if you're lying down, it's pressing on your abdominal organs, it's kind of causing pressure upon your lungs. It's really uncomfortable. You can feel breathless, and you often have really tight, distended skin, and it's really uncomfortable to have that much fluid. So it's a really nice, patients feel very, very relieved when you've shifted, 10 litres or whatever amount of fluid from their belly. So it's a nice thing to do for the patient. The way it works is similar to a tap. You do the positioning, you have a look with ultrasound, you find that free fluid, that kind of the black space that we've seen here. What you will see, by the way, on your first ultrasound when you do these is the bowel does float around a bit. Don't be too worried about that. Just try and find a nice pocket like is seen here. Okay, so how to do an acidic drain very quickly. Have a look at Geeky Medics before you do it as well. It's really helpful. First, before you do the drain, you're shifting a lot of fluid from a patient. So you need to take their weight and you need to do their observations before. Then you position them, again, saying you can tilt them on their side so that there's more fluid collection in one area if you need to. Often people do it on the left side. That's because if they've got gross hepatomegaly, the liver's not going to get in the way. Again, that's more of a tip pre-ultrasound. Always do ultrasound, it's safer. It's like I said, it's like a big cannula. You can see it there. There's a needle that's sheathed in a plastic tube. And then you have, like, in your acidic tap kit, you have the drainage collection and the bandaging that goes with it. And you find your space, you do your aseptic technique, you chloro prep, after marking the area that you want to do your flora prep, and you insert your ascitic drain, and then like a cannula, like a vein cannula, you withdraw the needle and you push in the plastic tube, and then you connect the drainage bag like a catheter, and then you let it drain. The important thing to remember is in a patient who is losing maybe 10 liters of fluid from the abdomen, there's a big hemodynamic shift often. Because they're losing so much fluid, they can often go quite hypotensive and tachycardic afterwards. To mitigate for this, we use human albumin solution, which is often referred to as HAS. And we generally give about 100 mils of 20% HAS for every 2 to 3 liters lost to a drain. Again, your trust will most likely have guidelines about using HAS on ascitic drains. And again, under the general rule, you don't want to drain more than 10 liters, and you don't want that drain to be in more than 6 hours because it's an infection risk. So the nurses staff will be monitoring, but if you've drained 10 liters or if you've hit 6 hours with that drain inserted, whichever comes first, remove the drain, remove the ascitic drain. During the ascitic tap, you want to do hourly observations. Again, your trust might have different guidelines on this, but at least hourly observations, and especially as well afterwards as well. It's really important to take regular observations to make sure that patient's not going hemodynamically unstable. And it's also important to take the weight afterwards to see how much weight the fluid that they've lost. So that's ascitic taps. And I just like to bookend that with, they can feel really scary, especially on your first F1 job. If you've not done that many like big procedures before, all procedures seem really scary when you do them for the first time. I remember taking your bloods for the first time, that felt really scary. But genuinely, like there's probably less skill involved in an ascitic tap than a cannula. So just make sure, have a senior with you, give it a go, and I'm sure you'll enjoy it if you like procedures. Cool. So that's kind of a lot of like the sort of ward-based stuff, the knowledge-based stuff. And I'm just going to have a little talk about more general F1, F2 stuff. So opportunities and portfolio building. In your first sort of weeks as an F1, you're probably not going to be super concentrated on, getting into training and things like that. But it's good to think about your Horus, especially, and trying to get on that early. So what I'd say is must-dos is, of course, whatever you need to pass the ARCP at the end of the year. The ARCP is similar to when you do your logbook in school. It's like an end-of-year review to say, have you done enough this year to move on to the next stage? And what is involved in that is SLEs, and so that's mini-KEXs, case-based discussions, DOBs, all the same stuff that you did as a med student. Unfortunately, it carries on, and you need to be logging these things when you do them, and it's way better to do it earlier than later. And just keep in the back of your mind that it closes April time, maybe. So it's not at the end of the year, it closes early. So make sure you have enough on there. Reflections, most trusts really like you to have at least 1 or 2 reflections per rotation. Some examples I've done is first on call shift, family conversations, like difficult family conversations. I reflect on a patient that got quite annoyed with me on my gastro rotation, and then discussing that with my seniors and then what I learned from that. And then also quite an easy reflection to do after each rotation, if you need a reflection, is what did I learn from my first rotation? What did I learn from my second rotation? And then, of course, must do supervisor meetings. Like in med school, all works the same. Contact your consultant. They might ignore you. Contact them again. Find them where they might be. Make sure you get your supervisor meetings done. Should do's. So coming out of the essential, and now what I think you should do, and I've made a point of this, but gastro practical skills. Especially if you're lucky enough to have a gastro job, I think it's a perfect opportunity to learn these and do a few of them as well. Audit QIP. You need to do an audit to pass, or a QIP to pass your ARCP. So make sure you get on that early. And again, Gastro is a great place to do quip. The quip that I did with a team, which I was very fortunate to do because a registrar was already doing it, and I just kind of hopped onto it, was we created a new performer on our IT system of Ascitic drain safety. So it had things like what you should be, it had drop down boxes of, the weight before, the odds before the Ascitic drain, how much fluid was drained, how much HAS was given, advice on what to do next. So we introduced that as a performer, led by one of the registrars, and that was really quick. I would say I think you should do some teaching. I think it's a really good thing to start doing early. It doesn't have to be on, no, it doesn't have to be on gastro if you're on a gastro rotation, but I mean, you're going to have gastro patients. But teach med students, it's nice to kind of become a doctor and then be able to step into that teacher role. And you guys are often some of the best teachers because you're fresh out of med school and you know what is needed to know in med school and what you found difficult. And then some nice to do things go above and beyond if you would like to do it. Research projects, I can't say I have, but research projects are really good to get involved with early. They're really good for IMT or specialty applications. Courses, I've done a point of care ultrasound course. That was in my F2. I've done a teaching course, and that's about it. But courses are really good ways to A, get some study leave, and B, boost your portfolio. See if you can get them funded by the trust, by the foundation program. And if you want to do some additional reading, maybe on some of the things that we talked about today, if you want to just kind of feel a little bit more embedded into a placement. I will say, do not feel bad if you can't do research projects, courses, teaching, additional reading, because you feel so overwhelmed by your first foundation program. It's a foundation job. It's a lot, so don't worry if you can't do these things straight away. Concentrate on the job first because it's a big step already. In that little box, if you are considering an application to IMT, so that's internal medical training, remember to keep all evidence for your portfolio and seek audit QI early on. So what I'm essentially saying there is if you do anything that's sort of above and beyond, just make sure you have evidence. The way that I've done it is I literally, because I came into F1 and everyone was talking about portfolio and I was like, what even is a portfolio? Where do I find one? Is it a physical thing? Is it an online thing? My portfolio is a file on my laptop where I just keep evidence of all of my feedback, signed documents from consultants, just a big folder of all the things that I've done. My ALS certificates in there, my BLS certificates in there, everything is in there. Any kind of compliments that I get on the ward, I put it all in that folder, and that's what I call my portfolio. So that's how I do it anyway. And when it comes to applications, you've just got all that evidence to input into like track jobs or something. Cool. This is maybe way ahead if you're starting as an F1, but not that ahead if you might have already done it if you're starting as a or you might be already thinking about it if you start as an SHO. This is the IMT recruitment page on NHS website. It would be worth going just to have a little look and getting an early idea of what is looked at for internal medical training applications. Essentially, it's these sections at the bottom. So postgraduate, so things like degrees and qualifications, presentations, the things like where you've maybe presented a poster at national, international conferences, publications, self-explanatory, teaching experience, and training in teaching and QI projects. So all these things will get you points. Lower down on the page, it will outline like what exactly gets you what exact points. So if you're thinking about boosting your portfolio early, I would mold it around this website because this is what will get you points. They do change year to year, but not by massive amounts. They do change. What counts as for what points. So if you have time, if you're interested, if you think you want to do IMT, and if you want to do either gastro or resp or whatever, go and do go and maybe have a little look at this and see how it works. Cool. So we've talked a lot about like what's expected of you, some knowledge, some top tips, diagnostics, investigations. And it's really hard, it's really easy to kind of get lost in the job when you start. And so just a little word about your well-being and looking after yourself. So like I said, it's a busy job. It will be a busy job. Gastro is a busy specialty. You will often find that your registrars and your consultants will be in endoscopy, and it will be either you and just SHOs or IMTs on the ward. And also, it's a medical job, so you will have your medical on calls and things like that. But there's always help. So if you feel stressed, if you feel like you don't know what you need to do, there's always help there. And it doesn't always have to be in the form of a consultant. Nurses know so much, especially if they had a lot of time on a gastro ward. They'll know loads and they'll help you loads with certain problems. Make friends with your nurses. It'll make your job and life so much happier. Regs are around, each other are around for some support, and then there's also your consultants. But there is always help, even on calls. You can always call someone. Make sure you go for lunch, and if you can, you get outside and you chat to people and have a nice time at lunch. It can be quite difficult because you feel really bogged down with jobs sometimes, but make sure you try and make some time for some lunch. In terms of how to do that, I'd say try and get your kind of time critical jobs done early. So once you've done your ward round and you see what jobs you have for the day, have a little look through and see which ones need to be done early so that you can go and just relax on lunch and do the less critical jobs after lunch. Exception reporting. I don't know if anyone's really mentioned exception reporting before, but essentially if you stay late or if you miss a lunch break because you were understaffed or overstretched or there was a very clinically demanding day, exception report. So you should be guided from the trust of how to do this. But essentially it's saying, I stayed this amount late. I stayed 1 hour late and I would like to be paid for that 1 hour is essentially what exception reporting is. It doesn't I think it's changed and it no longer goes to your supervisor for approval. I think it's either someone else or it doesn't even go for approval. But when I was in F1, it went to my supervisor and they approved it. But now there's not even that step. It's very, very easy. So if you work extra, make sure you get paid for it. I'd say try and prep ahead for on-calls, prepping meals and maximizing rest. So I don't know if you do nights, some F1s do, some F1s don't, but when I go into a block of nights, I like to prep my fridge with some nice food, like some good meal prep food for lunch, and also like some pizzas and easy to cook pastas when I come home, so that when you're on long days or on calls, it's as easy as possible, and you kind of home life is not as demanding as making a spag bol. So just prep ahead, know how much time you're going to have at home, prep some meals, make sure you get some sleep with your on calls. And if you're struggling and you feel like you need some help, please reach out to people. There's foundation teams, there's your supervisors, whether that's clinical, educational, whoever you have a good relationship with. It doesn't have to be a supervisor, it can be a trusted consultant or senior or a clinical teaching fellow or anyone. It's an expectation that you're going to need some help at the start. It's a tough job. You're straight out of med school. It's quite a lot at the start. So do not hesitate to reach out to people if you feel like you need a little bit of extra support. And it's surprising what people can do for you if you do that. Cool. So just make sure you look after yourself and try and enjoy your F1 as much as possible. And then final advice and top tips, and I'm on 57 minutes, which is good. Though it's the steady progression throughout F1, don't expect to know everything at the start. Like I said, you're expected to need some help, and you will slowly progress as you go on. I'd say show some interest and take up opportunities, even if they're scary. So that, again, procedures, maybe go to endoscopy, have that conversation with the scary reg at the tertiary centre. Show interest and I think the more you put in, the more you get out of a placement, and that's true for anything. Build a team as much as you can. So that's, get to know your nurses, get to know the receptionists, get to know the ward clerk, the HCAs, say hello to the cleaners, make it a nice work environment for yourself. And you will be happier going into work, I think. And then do your horse early, as I mentioned, so it's not all piled up when you need to get 9 mini kexes at the end of your last rotation. And this goes for anything. If you want to do IMT, if you want to do gastro, or if you want to be a surgeon, or if you want to do whatever, just I'd say tell people, because those people will tell other people, and someone will have some cool opportunity for you, and word will get around it, and it really helps for people to know what you want to do. If you don't know what you want to do, that's fine. Most people don't. But for example, my next job as a teaching fellow, I just told loads of people that I want to be a teaching fellow, and I pretty much got my next job because of that, because I got some good connections and managed to get some interviews. So yeah, that's kind of a progression. If you know what you want to do, tell people. Cool. That's Thank you for listening. If you've got any questions, please shout out. Now's your time. And if not, please scan the code and leave some feedback.